Hello there, Michael. This is Michael Popkin, a past president of the Academy of Consultation-Liaison Psychiatry and a past winner of the Hackett Award. It's so nice to have the pleasure of speaking with you today.
Well, thank you, Ted. Good to talk with you.
Always a pleasure. So as we are trying to develop this oral history of the Academy and leaders in the Academy, we would love to know how you first heard about the Academy of Psychosomatic Medicine, as it used to be called.
I believe Richard Hall was the individual who's responsible for my eventual involvement with the Academy. He and I had served in the Navy together. And at some point in the year or two afterward, I think Dick induced me to go to an Academy meeting. So I would think it was somewhere around 1976, possibly 1977, was the first time I'd gone to an Academy meeting.
So when you went to that first meeting, how big was it? And what did you think of it?
Let me try to characterize it, because I think probably this is relatively important. The Academy at that point, or at least when I first encountered it, was largely a group of general medical practitioners who had what I would call some sort of passing interest in psychosomatics. And the meeting, in fairness, was really more of a social event than an academic one. The emphasis was really on having a good time, and there were a lot of events that involved wives as such. And what stands out in my mind was the first meeting I went to, which might have been either in Florida or in Nashville. The entertainment, the major part of the entertainment one evening was a group of cloggers.
Nowadays, that would be bloggers.
Well, yeah, but these were cloggers, you know, that, and I didn't really know much what to make of it, other than, I mean, they were congenial enough people. Dorfman was there, by the way, I mean, because the journal existed at that point. And so I think I met him at one of those early meetings. But in the beginning, the Academy, as I understood it, was really more of a social event than an academic one, and consisted largely of medical practitioners rather than psychiatrists. You also have to remember that this is still in the era when classic psychosomatics was still kind of mainstream, you know, going back to the Holy Seven from Franz Alexander and the, you know, the 7 major psychosomatic conditions. And so I wish I could remember the sequence, but I think what happened was that when Dick and I finished our time in the Navy, he stayed in Florida, and we started going to the meetings regularly, he and I, because we were writing something, you know, doing studies together. And the Academy became a place for us to present our work, and then subsequently to interface with other people who were particularly interested in consultation and those kind of issues.
So about how many meetings do you think you've attended over the years?
I don't think I missed Very many, if any, in the period between the late 70s and probably the time I actually gave up my academic job in 2015. So, yeah, there's a stretch.
That's a good long run.
Yes, yes, there were a lot of meetings. A lot of
So
meetings.
from the time that you first joined the meetings in the 1970s to the last decade, how do you think the meetings have changed and how do you think the organization has changed?
I think it changed very substantially. I mean, you might even really say night and day. What happened in somewhere in the mid 80s, a couple of people, particularly, of course, Tom Hackett, and also I think Bill Webb, um, were instrumental in substantially overhauling the academy from the social entity that I was describing that it had been. And the goal that, and I attribute this mostly to Tom and Bill Webb. Um, the goal was to really make the academy the home for consultation liaison psychiatry. And over a period that probably started somewhat before Tom actually, in the last year of his life, became the president. Um, so it's a process that started somewhere in the mid 80s about restructuring the academy to have it focus on consultation work. And of course, and I don't need to explain this to you, but Tom was not particularly a big advocate of the term or the concept about liaison work, though he certainly integrated himself very effectively with medical and surgical services, but his focus was much more on the consultation side. And of course, Tom was the reason I became a consultation psychiatrist. So,
How did he do that? How did he influence you?
by his inimitable clinical prowess and his interaction with patients was just incredible to me. I mean, Tom had a very unique style. Um, he had boundless curiosity about patients and what I call an unswerving interest in the human condition. Tom could talk to anybody, and it wasn't so much about the formalities of an interview. Tom's goal was to find a way to relate to the patient, and he would drop process and the formalities of an interview as soon as he identified a point of connection between him and the patient. And he was just a remarkable clinician, and he was brilliant and animated and spirited, and he was just wonderful. And yeah, I admired very much his ability to relate to people and the style in which he conducted himself. And he was in many ways unorthodox or unconventional, but he did effectively forge links with patients who really understood that what they had was a physician who was really caring and concerned about them and really would be on their side or their advocate in the process. So he did change my life in the year that I worked with him. And yeah, he just was fun. I mean, he made clinical work fun. He's a remarkable individual, and we lost him much too early. My investment in the academy was, I'd been there, I think, before Tom actually became involved. I had been attending meetings, but when Tom became involved, it became a very nice way for me to see Tom on a regular basis and spend time with him. And that was also part of the attraction. But there was a 5-year period from the early 80s till about the time Tom became president in 87, when the 5 people who were presidents set about restructuring the academy to make it the home really for consultation work. And the academy in the ensuing years became much more academically directed, much more directed to the idea of people presenting their ideas and their work, and it being a place to network and find out what your contemporaries were doing and what they were thinking. It was a much different venue, a wonderful one in which most of my major professional interactions and connections, from various groups of people who did consultation work at different places. I mean, within Mayo, we always had interactions between the University of Minnesota and the Mayo Clinic, and then there was Iowa. But with the academy, we interacted with people from, of course, Boston, the Mass General, Ned and George, and you, and John Schuster, and so on, and then as well as a whole group of clinicians from the New York area, particularly the group at Sloan Kettering with Jimmy Holland and Mary Jane Massey, and Bill Breitbart, and Tom Wise and Richie Goldberg down in Georgetown, and some people from Emory in Atlanta as well, and Jim Levinson. So just a whole roster of people. And it was a much smaller setting than the annual APA meetings, which, somewhere between 15 and 20,000 people would attend, whereas the academy in the beginning probably had a membership of 400 or 500, which grew in the 80s to approach about 1,000. And it was just a fun and very informative place that was an important place to meet your peers, present your work, exchange ideas, and frankly, just form lasting friendships, many of which have even continued for me all these years.
Well, as you develop these robust connections with people at the academy who were at institutions across the country, what kind of roles did you partake of in the academy?
Well, originally, I joined the council of the academy, I think in 1988, probably through Tom's good graces before he actually left. And so I was on the council for, I think, a full 10 years. And then in 92 and 93 was the year that I was president. And of course, in that format, you stayed on, I think it was 5 years on the council after you'd been president. And so I think that was completed the rest of the decade for me. So my formal appointments ended, I think, in 98, but I, continued to attend the academy for many years thereafter.
So the organization changed a lot. Its social nature to a more academic nature, though it still maintained sociabilities, changed a lot. How do you think the journal changed?
Um, I think the journal changed substantially in that time period too. And um, I think when I first encountered the journal, it was less rigorous, let me put it that way. And it was, I believe, almost exclusively sponsored by pharmaceutical ads in terms of, its cost and its publication. And I think the standards just changed very substantially. Also, you have to remember the field changed in this time period as well. We went, from the era of psychosomatic medicine in the old classic sense, with the Holy Seven psychosomatic illnesses and a big emphasis on physiology. And the companion in those years were a lot of descriptive case reports. And there was a movement in terms of a lot more focus on data collection, a lot of focus, of course, with the changes in DSM-4 was published, I think, in 93. So whereas DSM-3R first, and then 4, and the focus then became on epidemiology and nosology, the influence of Washington of St. Louis. So what had heretofore been more emphasis on the old kind of psychosomatic framework changed to a lot more attention to data, to epidemiology, nosology, psychopharmacology, which hadn't, up until the beginning of the 70s had not been that central to our discipline. And I think just a lot more attention to the consultation side of the coin.
And you did a lot of research with Dick Hall about what people want and expect from consultations and how they're done.
Yeah, I mean, we studied the process of consultation and the outcomes, particularly of consultation. The idea was, and this is one of Tom's ideas, that the important thing is to figure out how to deliver a better clinical service. And we thought the way, or at least one way to make some progress toward that goal was by actually monitoring or measuring outcomes. And so we set about, in a variety of ways, trying to gauge the outcomes of consultation in terms of recommendations and which ones were implemented and which ones were not implemented, and the variables that influence those things. So that was the first part. And then we kind of in Minnesota shifted gears and became much more interested in the epidemiology of psychiatric conditions and various medical problems. Minnesota is a major transplantation center for originally renal work and then subsequently pancreas, a little bit less for heart and liver. And a lot of my work at Minnesota was in support of the various transplantation programs, particularly pancreas. And so I was interested in the epidemiology of psychiatric conditions in the transplant recipients. And that was a partnership, particularly with the surgical department at Minnesota, in terms of they appreciated having support for the psychiatric care and management of the patients undergoing transplantation. And in exchange, we got to study their recipients. So it was a nice working relationship.
At
But
this
that's,
point,
go ahead.
where do you think the field is going? and where do you think it should go?
Can I go backwards?
Yeah,
Because I want to compliment you on your editorship and what actually the changes that you brought to the journal, which I think improved the academic standards and rigor. And the journal became, I think, much more competitive in terms of the broader psychiatric journal population, so to speak, and more interesting to a lot of people than it had been previously. I don't think it was as restricted, and I think a lot of that was because the focus was less on kind of classic issues and more on the actual clinical issues that patients seen in consultation represented.
it
So,
takes a village to put a journal together.
well, it also takes one highly energetic editor with a lot of vision and a lot of recognition of what is clinically important. So my hat has always been off to you, Ted, for your editorship work, among many other things.
Thank you.
My pleasure.
So where do you think the field is going, and where should it go?
Well, it has come through a lot of evolutions, I think. And I guess the thing the various things that have excited me are brain circuitry things just fascinate me. The idea of our ability at some point, hopefully not too far down the road, to understand a lot more about the brain as a circuit and the various aberrations and conditions that it faces. I've had two personal areas of interest that I guess I still hope get further clarified. And one is the problem of depression in medically ill people. Whether medical depression is a discrete entity or whether it varies depending on what medical condition it's coexists in or is superimposed upon. And I just have always been very interested. I don't think my bias has always been that it's not the same thing as a regular affective disorder in somebody with no medical problem. But I'd like to see that sort of clarified a little more. And the other is I'm very interested in changes in cognitive function that accompany various physical illnesses. So I guess more neurocognitive focus. I'm not even sure if that's current terminology, but that's.
Well, you have the stature that you can create your own words if you need to.
Well, I wish, and oftentimes I guess I do, but what are they called? Neologisms?
So if you have the opportunity, and you do right now, to use this platform to provide advice to younger members of the organization, how would you guide them?
I, when I, a number of years ago, was honored to receive the Hackett Award, part of the title of my talk was about what I called old verities. And a lot of them were based on Tom Hackett's principles. And I
That was
said,
20 years ago, I believe.
Yep. I think it was. Maybe not quite that far back, but 15. Anyway, what Tom emphasized as what I called subsequently old verities is that it's important in consultation psychiatry to maybe in any line of work that you choose, to follow your own intuitions, ideas, curiosity, and passion. And I think curiosity was a big driver for Tom. Um, it also was directed to finding a way to be able to relate effectively to the patient, which I mentioned before. And I think people on consultation services need increasingly to figure out how to partner and integrate effectively with medical surgical colleagues, um, whether under the guise of liaison or under just a partnership arrangement that benefits both sides. There's a lot more appreciation of integrated care now than in the years when I was on the consultation front lines. But I think the goal for any clinician is still, how do you deliver an effective clinical service? And that still should be the driver, along with you have to do what works individually for you. I mean, what worked for Tom and what worked for me may not be what works for the next individual, but part of your task as a consultation to psychiatrist is to figure out what your particular strengths are and how you can best, in service of the patient, help that individual deal with their circumstances, the medical or surgical illness that they're confronting, or the psychiatric concomitants of that.
Would it be fair to say that it's also important to find out what makes you happy and what's fun to do?
Yeah, very much so. I think that was part of, I think, why Tom was so special. He literally was buoyant. He would come out of an exchange with a patient, and he would just be somewhere between awed or astonished by something that the individual had shared with him, or that he understood about the individual. I mean, I can't remember a debriefing in which Tom wouldn't be just lit up about some aspect of the individual he just encountered. And as I said, forged a link with, which he was just wonderful at doing. So
If you hadn't have had the year working with Tom Hackett, how
I'm
would
sure,
life have been different for you?
I think it'd be a lot different. I'm not sure exactly where it would have gone. I mean, I went to psychiatry in the first place because I thought that what goes on inside people's heads was the most fascinating thing in the world. And I ambivalent a lot about going to law school. My father was a litigator. Um, and instead, I opted for medicine explicitly because of psychiatry. And when I got to my psychiatry residency, I didn't have a clear idea of what I would subsequently do with it. But my task in residency was to learn as much psychiatry as I could. And right in the middle of that came Tom. And yeah, I mean, he was a unique individual who did literally change my life. Had I not done that, I don't know, Ted, maybe I'd have, I spent a lot of time thinking about the interface between law and psychiatry.
But you also did medical training at NYU Bellevue.
Right, right. And I was, it was a combined med psych internship, and which was actually also a wonderful experience. Bellevue, was the old Bellevue in those days, as you know from your dad. And I was offered late in the year a medicine residency. Not that I consciously sought that, and I thought hard about it, and then I finally decided that I needed to go home with the girl that brought me to the dance, so to speak. And consultation psychiatry afforded me a way to do that, to have a foot in both worlds, with an emphasis on an amount of medical awareness and knowledge that I think would benefit most psychiatrists, and I think increasingly has. So, yeah, my life undoubtedly would have been very different without Tom Hackett, but I'm not sure I know the answer as to.
Anything else you'd like to tell people that are viewing this?
Boy. You, in the preparatory questions, you'd asked some things about the difference between the Academy and some of the other organizations at the time. And I had thought a little bit about that. So let me just say something briefly. I had been a member for many years of the American Psychosomatic Society, and I actually served on its council for, I think, 4 years. A very different organization than the Academy, with much more focus on physiology, and a little bit more on basic science, if you will. Columbia, Don Kornfeld was part of the American Psychosomatic Academy, and actually, I guess Peter Shapiro bridged both worlds, but just a very different organization, and with a little less concern, and I don't think I'm being critical, they just were in a different direction about the actual work of consultation itself. They were more interested in either physiology or some basic science aspects, or even the continuation of the old, more classical psychosomatic focus. So what else would I tell people? Be fortunate to have good mentors is what I tell you. Mentorship makes an enormous difference. And yeah, you have to be very fortunate in terms of, who your mentors are.
And in that regard, I have always valued you as one of my mentors and a person that opened the door to being on the council and on committees. And my life would be different if it weren't for that. So thank you.
You're more than welcome, Ted. You've done a remarkable job in every aspect. I think the Academy for me has just been a wonderful place over the years, in terms of professional development, a place to present and share work, personal relationships that I really wouldn't trade for the world. They're the best of my professional career. So I feel very fortunate in terms of the people I worked with, and the idea that I could bring my own trainees to the Academy, and that I kept up relations with a lot of people over many years. And yeah, I was fortunate enough to progress into a leadership position. And yeah, I'm very grateful for everything the Academy brought me. And I'm
The blending of personal connections and academic rigor is a nice thing that the Academy has facilitated.
It has. It really has. And yeah, I think it's remarkable. You had one other question that I wanted to comment on, because it was kind of looking back. Something about during my term as president, and the things that happened in that year, I mean, are a long time ago, but I think a couple of them are pretty substantial. One is David Gitlin started the process of developing standards for consultation liaison training in residency, because strangely enough, up to that point, CL was still kind of an elective in most training programs. So I think that was kind of important. Tom Wise began the process, which he then carried into the year of his presidency, about practice guidelines for CL, which hadn't been written previously. And a third thing that I look back at and am kind of pleased about is that my presidency year was the beginning of a women's caucus within the academy, started by Barbara Schindler and Ruth Landum, which I think is important. We also had a year in which, of course, an inordinate time was directed to the issue about subspecialty status, or what was then referred to as added qualifications. And two good things happened in 1992. One is that the American Psychiatric Association Assembly in November of 92 approved a proposal for added qualifications for the, what was then called psychosomatic medicine. And so did the APA Board of Trustees in December of 92. But later in early 93, the American Board of Psychiatry and Neurology, I think the term was red lighted the proposal, which then took another 12 years to actually get accomplished. So interesting time. I think I've pretty much covered what I had hoped to say.
Fantastic. Michael, as always, it's been a pleasure spending time with you and talking with you and getting your perspective on several decades of your past and the relationship with the Academy.
Ted, as usual, my hat is off to you. Thank you very much for making the opportunity possible for me. And
I look forward to more of our gatherings at meetings and beyond.
I hope so. Thank you, Dr. Stern.
Michael, it's been a real treat.
Okay.